Hello, everyone. I would like to invite the audience for the last presentation of the CME series on lysosomal storage diseases. For the ones who don't know me, I'm Ozlem Goker-Alpan. I'm the founder and chief medical officer of Lysosomal and Rare Diseases Research and Treatment Center. On today's presentation, we're going to focus on central symptoms and comorbidities in lysosomal disorders. But before we start, I would like to wish everyone a happy, healthy, prosperous new year. These are my disclosures. And as most who deal with lysosomal disorders know, lysosomal disorders, the majority of them have some sort of central nervous system or brain involvement. And some of them actually presents with pure CNS involvement with very little or no visceral involvement. And as a general rule, the ones that has a juvenile and infantile presentation, they do also present with the central nervous or brain involvement. So the disease severity in this slide goes from MPS that can have attenuated forms and also the ones with the primary central nervous system involvement, to Fabry disease that doesn't have an infantile presentation, but it is associated with central nervous system involvement as presenting with strokes. So in the most severe presentations, the neurodegeneration can begin in utero, such as MPS types 4A and 7, type 2 Gaucher disease, GM1 gangliosidosis, Niemann-Pick disease, type C, Farber disease, infantile free sialic acid storage disease, and mucolipidosis type 2, non-immune fibrosis fetalis. So when we teach the medical students, we always remind them to actually test for lysosomal storage diseases as we are evaluating a baby with hydrops in utero, in addition to congenital infections and chromosomal disorders. So to expand on this notion that brain is an organ that not only regulates the electrical activity and other lively functions, it also regulates the mood, the behavior, and also the emotions. So lysosomal disorders, in addition to primary nervous degeneration, they can present as a psychiatric disorder. And one of the differential diagnoses of psychosis or psychotic presentation should be actually a lysosomal storage disorder as well. So if you run through the list again, MPS 3, Sanfilippo types A through D can present initially at childhood as ADHD or pure hyperactivity or aggressiveness, followed by cognitive decline. And these children initially was followed with a diagnosis of ADHD, and they kind of start falling off the curve educationally, and then before they they present with the prime manifestations of Sanfilippo disease. The other disease on the list is MPS 2 or Hunter disease. The milder versions they do not present with significant visceral or facial involvement, may present with hyperactivity followed by cognitive decline aggression. This could be part of the whole disease spectrum. And similarly, monozydosis can present with psychosis and hallucinations. Niemann-Pick C patients, C1 and C2, can have a psychiatric presentation. Actually, there is a family that we used to follow. These were two siblings that presented with bipolar disorder, and nobody recognized actually they had a vertical saccade abnormality, and until they got diagnosed with ataxia and the other presentation of Niemann-Pick C in their mid-30s. Similarly, MLD, which is almost a pure CNS disorder, can present similarly with ADHD, dementia that may mimic a frontotemporal dementia, and psychosis. Similarly, Tay-Sachs and Senhoff can present with depression, delusions, psychosis, and schizophrenia diagnosis may antedate the actual diagnosis of lysosomal disorder. In Fabry disease, we do see depression quite often, and depression is, we regard that as a part of the disease rather than situational or secondary depression that is associated with presence of a chronic disorder. Gaucher disease, we often encounter anxiety, and almost the patients that I follow are treated for depression or anxiety. But having said that, the neuronopathic forms of Gaucher disease, we see, especially in Middle East countries, there is a report from Egypt that children exhibit hyperactivity, aggression, but my experience and the US experience is these patients may present with autistic behavior prior to the diagnosis of Gaucher disease. So I'm jumping from one subject to another, but now we're going to talk about a little bit the comorbidities, or the association of neurodegenerative disorders that we encounter in the heterozygotes in addition to the homozygotes, that is characterized by the aggregation of proteins. To be exact, this is synuclein. So we're going to be talking about the synucleinopathies and their association with lysosomal disorders. So this slide depicts the theory that a mutant lysosomal protein may affect the lysosomal functions and lysosomal structure and integrity, and may be a culprit for the fibrillization of the aggregate proteins, aggregate-prone proteins. So in this case, we're going to be talking about synuclein that leads to ultimately neuronal cell death. So in addition to the mutations, so we are expecting this organelle dysfunction, decreased aggregate clearance, that is mainly the jobs of the lysosome. So lysosomal clearance is very important in the proteins that are aggregate prone. And since synuclein, there is an earlier article that has shown that synuclein and LIMP2A is the protein of that helps synuclein to shuttle in the lysosome, and synuclein, mainly the aggregated synuclein, gets cleared through the lysosome. So this brings us to obviously the association of Gaucher disease, or the GBA mutations, with Parkinson disease. So this initially this was an observation, but through the major work of the NIH, Dr. Sidransky and her lab, we now know that glucocerebrosidase pathogenic variants are the major or the prime genetic cause or association with Parkinson disease and other associated synucleinopathies. So this slide shows a publication from 2017 where the researchers looked, this was a multi-center work, and the researchers looked the association of other lysosomal disorders in the patients with Parkinson disease. So they performed whole exome sequencing from more than 1,000 patients with Parkinson disease, and they compared to control subjects. So in the Parkinson cohort, there was a significant burden of variants that are associated with lysosomal disorders and with Parkinson disease risk. And obviously, there was the strong association of glucocerebrosidase, GBA, or the locus that encodes for the Niemann-Pick disease. In addition to these known or already established loci, there was also association between CTSD, which associated with ceroid lipofuscinosis, CLC17A5, which is sialic acid storage diseases, and ASHH1, which is associated, actually, that is the mutations cause Farber disease, and also SMA, spinal muscular atrophy, myopathic encephalopathy, and also implicated as candidate Parkinson disease susceptibility genes. So these obviously expands the notion of lysosomal disorders associated with more common, actually most common neurodegenerative disorders, which is the Parkinson disease, Lewy body dementia, MSA, and so on. And in this study, the majority of Parkinson disease cases have at least one putative damaging variant in lysosomal storage disease, and about 1/5 carry two variants. So from this point on, I would like to give the word to Dr. Swati Sathe, who has a colleague and friend. Dr. Sathe has an extensive experience in the neurological manifestation of rare disorders, to start with the lysosomal diseases. She is the current medical director of Cure Huntington Disease Initiative, CHDI Foundation in New York. But she received, after receiving her medical degree from India, and then she completed her medical residency at NYU Langone. She worked and she achieved a fellowship in lysosomal disorders. And then she moved to research area where she was the director of the Pompe Clinical Development Program at Amicus Therapeutics. So in addition to her position as being the medical director of CHDI, she also is a volunteer neurologist and associate professor at Rutgers, New Jersey Medical School. Dr. Sathe has extensive both clinical and bench research. So her primary research interests are enhancing awareness and diagnosis of rare disorders, exploring the natural history as it relates to endpoint development, and she is a pioneer in many advocacy attempts such as Cure Codacil. So it's going to be our delight to listen to Dr. Sathe on today's presentation. Thank you.
Thank you, Dr. Goker-Alpan, for the kind introduction. I appreciate this opportunity to present on the central nervous system symptoms of lysosomal storage disease. So thank you to LRDTC as well as Affinity Med for this educational program. Just to start off, there are a few disclosures. I have no conflict of interest, and I will be presenting non-FDA approved products in development for lysosomal storage disease, and I'll indicate them as we go along. So just a brief slide, not that this particular audience would need an introduction, but the first description of lysosomal storage disease was independently by Dr. Tay and Dr. Sachs in 1881, which constitutes the Tay-Sachs disease. At the time, although it was not known that it's a lysosomal storage disorder, because the lysosome was eventually discovered in 1955. And the first demonstration of a link between enzyme deficiency and the subsequent storage causing a lysosomal storage disorder was for Pompe disease by Hers in 1963. So in general, the scheme behind lysosomal storage disease is that there is a defective lysosomal acid hydrolysis of endogenous macromolecules, and that leads to accumulation of these molecules in the cells with consequent either impairment of the cellular function, or in most cases, especially in the CNS, cell death. So I'm going to speak about the pathophysiology of neurologic involvement in LSDs, but before that, I just wanted to give an overview of the sphingolipidosis pathway. There are other lysosomal storage disorders beyond sphingolipidosis. However, these constitute a major bulk and are more common than the other neuropathic lysosomal storage disorders. And what's very evident here is that each of these disorders is about one step away in the metabolic or the catabolic pathway in the lysosome. And although these are closely related in terms of their metabolic position, the manifestations of each of these conditions may be very, very different. However, there are some commonalities. So, GM1 and GM2 gangliosidosis are purely or mostly gray matter disorders and have a lot of overlap in their presentation. Whereas Krabbe and metachromatic leukodystrophy, which are on the right lower hand side here, are mostly myelin disorders, cause leukodystrophy, and again have similarity in their presentations and outcomes. Now, not all of these are necessarily enzyme deficiencies, and we'll talk a little bit about those in the future slides. Some of these, for example, especially type 1 form of Gaucher disease, for example, will have minimal to no neurological involvement. And so not even though they may be one step ahead away from each other, the manifestation of the disease may be totally different. And this is generally considered to be because of the utilization of a particular macromolecule by that specific tissue type or cell type, and then the subsequent accumulation of it when it is non-degraded, leading to cell impairment. Not every cell type in the brain or in the body will use a particular metabolite in a similar fashion, produce it in a similar fashion, or degrade it for that matter in a similar fashion. And we attribute these differences in manifestations to mostly that aspect of anabolic and metabolic and catabolic pathways. So just a few slides on the basics of lysosomal physiology. So lysosomes are usually synthesized, the primary lysosomes in the Golgi apparatus. These are the milieu of the lysosome is intensely acidic, and they contain a whole host of hydrolases, which degrade macromolecules in a stepwise manner. And so, product A is converted to product B to C to D, bringing it down to the basic metabolic components, which may either be expelled from the cell or may be reutilized by the cell for future anabolism. Now, the products that are delivered to the primary lysosomes for degradation may either come from outside the cell by the process of endocytosis, as shown here, and the primary lysosome will fuse with the endosomes to imbibe those exogenous molecules, or there may be byproducts of metabolism coming from inside the cell itself in the form of autophagosomes, which will then fuse with the lysosomes, forming the secondary lysosomes. Eventually, when the catabolic processes are over, what's left behind is the residual body with this degraded material. Now, what happens when there is a enzyme missing, so to say, the normal lysosomal degradation pathway is disrupted. And in this particular instance, the enzyme that converts the product B to C is missing, and that will lead to accumulation of product B. Being on the catabolic side, absence of C usually doesn't cause much of pathology, but the accumulation of product B and the subsequent damage to the cell is what causes pathology. So as we said, most often it is the missing enzyme or defects in synthesis or folding of the enzyme that lead to lysosomal storage disease. However, there are LSDs caused by other mechanisms. For example, activation defects such as either there is saposin deficiency or GM2 activator deficiency, in which case the phenotype is usually like the primary lysosomal disorder. However, it is not because of the enzyme itself, but it is because of the deficiency of the activator of the enzyme, and the phenotype does get modified a little bit. There may be membrane protein defects such as in Niemann-Pick C, usually related to the cholesterol metabolism, post-translational modification defects such as multiple sulfatase deficiency, targeting defects or defects in the fusion and of the primary lysosome with the endosome, such as in mucolipidosis. So these are some of the other mechanisms by which a lysosomal storage disorder may present itself. In case where there is an enzyme deficiency, a pure enzyme deficiency, the phenotype is largely related to the residual enzyme activity. So the residual enzyme activity in turn is dependent on the kind of mutation that's present in the gene. So if the mutation is a severe or a deleterious mutation, such as a nonsense mutation that indicates a stop codon, or a frame shift mutation, which will also lead to uh, either non-formation of the protein or degradation of the protein. In that case, the residual enzyme activity is almost nil, and that leads to a severe early onset form of lysosomal storage disorder. However, if it's a missense mutation and maybe away from the catalytic site, that will lead to some amount of residual enzyme activity being present, and the phenotype getting modified to a milder one, and may lead to survival for even decades. Now, the pathophysiology may be dependent just on the primary effect of the storage or due to secondary effects of the storage, such as macrophage or cytokine activation. And some lysosomal storage disorders do have an inflammatory component, such as Krabbe disease. There is a deacylated form of the metabolite, usually called a psychosine, and there may be impairment of the function or pathology related to this altered form of the metabolite, as we see in Fabry disease. And of course, once the capacity of the lysosome to accommodate for this accumulation is exceeded, then there's extra lysosomal accumulation of metabolites, and that will lead to further damage, which very commonly seen, say, for example, in Pompe disease. Now that leads us to what kind of manifestations do we see in lysosomal storage disorders. So these are just listings, and of course, we don't expect that everybody knows this by heart. However, there is an overwhelming theme. So the most common organ involvement is the eye, and you'll see a number of abnormalities starting from corneal opacities and cataracts to retinitis pigmentosa and optic atrophy. Now, if we look at optic atrophy, a number of lysosomal storage disorders may be responsible for it. However, retinitis pigmentosa is quite specific for neuronal ceroid lipofuscinosis. So in some cases, a particular finding may be diagnostic of a particular lysosomal storage disorder if the history that the patient presents with is consistent as such. For example, the corneal whirling of Fabry disease is diagnostic of Fabry, very useful for picking up patients early in the disease, even while undergoing, say, routine eye examination by an optometrist or an ophthalmologist. More severe neurological manifestations, of course, include myoclonic seizures, cortical atrophy, which may be cerebellar or cerebral atrophy. Fabry is a unique disease where blood vessels are affected, and so stroke-like events are very common in Fabry disease as a neurological involvement. And then manifestations related to a specific suborgan within the brain. So ataxia may be related to cerebellar atrophy or hypoplasia, extrapyramidal signs related to basal ganglia involvement, peripheral neuropathy, and then dementia or psychosis. Psychosis or behavioral abnormalities are in general not that common in lysosomal storage disorders. However, we do see them with late onset GM2 gangliosidosis or late onset Tay-Sachs disease. In Sanfilippo type 3 or MPS type, in Sanfilippo disease or MPS type 3, especially in children, the behavioral disorders may be more pronounced, hyperactivity, difficult to control behavior, aggressive behavior are some of the manifestations of behavioral manifestations of LSDs in very specific disorders. So neurological involvement in LSDs is very heterogeneous. And as we said, it may be related to the residual enzyme activity, but I would like to highlight the spectrum of neurological involvement and the variation of the phenotype based either within a subtype of a disease. So for example, Gaucher type 3 and all the variations within Gaucher type 3 may be related to a specific mutation, or it may be an allelic disorder, however present in a very different manner, or variation within a subtype of a disease. And so as we were speaking about Gaucher type 3, these are 4 individuals with Gaucher type 3, diagnosed as Gaucher type 3. Each one of them may have a different mutation. And as you can see, the baby on the extreme right has a clear ophthalmoplegia. However, the age of onset, the degree of hepatosplenomegaly, and the degree of neurological involvement is very different in each of these patients. Some phenotypes are very mutation specific, and I've highlighted two here. One of them is a homozygous D409H mutation in Gaucher disease, which causes a type 3 variant. However, it also causes cardiac involvement. And on the right, we see the axial chest CT showing the aortic valve calcification, as well as the hydrocephalus, which is very specific to this particular mutation in the subtype of Gaucher disease type 3. And we do not have enough explanations as to why this particular mutation should cause an additional involvement of the aorta or the heart. And there's clearly a genetic modifier effect here that we have not elucidated yet. Now, within a same mutation or within the same family, here is an example of siblings with Krabbe disease. On the left is the brother, who was the older sibling, who already at 17 had weakness of the right hand, and the overall illness was fairly rapidly progressive. Eventually became bedbound with spasticity in all 4 limbs, and had a much more severe phenotype than his sister, who we happened to see when she was 29 years old, and had a very, very localized involvement. And if you look at the MRI on the right side, she had temporoparietal regions just located on one side of the brain. She had that's on the right side of the brain, and she had specific weakness on the left side. And what she really manifested, along with the weakness and the spasticity, was a alien hand syndrome, where the arm would do things such as pull her hair or grab things without she having any control over that activity, which was very unusual for this kind of presentation. Now, this kind of presentation without the history of the brother may very well have been missed for other demyelinating disorders such as MS, which is very often what happens in late onset leukodystrophies, that if it's an unusual presentation, then other demyelinating disorders become or may seem more likely in the differential diagnosis than, say, a storage disorder. And then within a subtype variability. So here I would, as we said, the general scheme is that, more severe the mutation, earlier is the age of onset, more severe is the phenotype, and the survival may be limited. Now, in case of severe classic infantile forms of lysosomal storage disorders, such as in Tay-Sachs or Krabbe, they are not very heterogeneous. The onset is fairly homogeneous, and the progression is also homogeneous. But as soon as it becomes a little late onset and there is a residual enzyme activity, then the age of onset and the progression may really be very, very different, even though they're all, say, juvenile Tay-Sachs or late onset Tay-Sachs. Now, this is very important because in situations where therapy is available, for example, in Pompe disease, even a small change in the residual enzyme activity will change the survival or will change the outcome of the patient, even when treated with enzyme replacement therapy. So now, for example, I put this example of Tay-Sachs disease here. We have 3 forms: the infantile onset at around 6 months, and then juvenile onset, we say early to mid childhood, and late onset, say beyond teenage. And if we look at the manifestations and the involvement of the organelles of the brain, it is very, very different. And what is most striking is that cherry red spot, which is the highlight and which is the diagnostic feature of most of the gangliosidosis, is totally absent in late onset Tay-Sachs. We will not be able to comment on the involvement of anterior horn cell or basal ganglia in infantile because the children become bedbound very, very early, and spasticity is really what happens in the beginning, and eventually there may be hypotonia. Cerebellar involvement is not seen in infantile and not even recognized as, say, a pathological feature. However, severe cerebral atrophy and ataxia dysarthria are the prominent features of late onset Tay-Sachs. So the variability as the residual enzyme activity increases is drastic in some of the lysosomal storage disorders. And here is just an example of how attenuated can the phenotype be. And here I give example of Pompe disease, because classically Pompe disease is an infantile presentation, onset before the age of 6 months, uh, severe failure to thrive, cardiomegaly, and untreated death usually occurs around the age of 1 year or a little later. And what we see here is a 78-year-old woman who has had muscle weakness for 26 years. And for about 20 years of those, she was diagnosed as limb girdle muscular dystrophy. She had extensive workup. Had two muscle biopsies, several EMGs, and the way this particular patient was diagnosed was that she was not happy with the diagnosis of limb girdle muscular dystrophy, because there are several subtypes of limb girdle muscular dystrophy, and she wanted to know what exact subtype she belonged to. At the time, genetic testing was very expensive, and diagnosing a particular subtype of limb girdle muscular dystrophy was probably not going to be helpful for her. So we decided to test her for Pompe disease because therapy was available. And we explained to her that if she has Pompe disease, then she might actually be able to be treated, and we regard that as more important than ascribing a specific subtype to her muscular dystrophy. And that's how we send for testing, never ever expecting that the test will actually be positive. And lo and behold, she did have low levels of alpha glucosidase and eventually had two mutations uh, in alpha glucosidase, the diagnostic of Pompe disease. I think the one curious part about this patient is that then she declined therapy for Pompe disease. Now, as we said, that sometimes we may have a little different phenotype, uh, but overall, the presentation fits a particular gangliosidosis or a particular lysosomal storage disease, and very often may happen because of an activator deficiency and not because of deficiency of the primary enzyme. And here is one that was because of a GM2 activator deficiency. This particular patient presented at 15 months, which is a little later than what classic infantile Tay-Sachs patients would present. And she had failure to thrive. She did have a cherry red spot. She had microcephaly instead of macrocephaly. And she had easy startle response. Her brain MRI this time was unremarkable. She had seizures and a very abnormal EEG. Overall, the presentation was like gangliosidosis, likely GM1 or GM2. And as we said, this was because of a GM2 activator deficiency and not because of HEX-A deficiency. This is one other patient who really had all hallmarks of a storage disorder. She had progressive involvement of one neurological organelle after another, starting with cognitive decline, indicative of more dementia or a gray matter disorder, seizures, and then myoclonus eventually had a peripheral involvement with muscles, and EMG showed anterior horn cell involvement, then which led to eventual involvement of the lung function. She didn't have a cherry red spot, and finally extrapyramidal involvement with dystonia and Parkinsonism. And as you can see, from age of 6 to 9, really there was no diagnosis. This patient underwent extensive testing, and eventually the whole genome sequencing identified mutations in acid ceramidase, making this a diagnosis of neuronopathic Farber's disease. Neuronopathic Farber's disease has really been described only in the past, I think, 10 years or so, and cases have been reported mostly picked up on whole genome sequencing. So this may be one case where a newer modality has been able to identify a newer phenotype of an older disease, and this was very unusual. Okay. So now that we have focused on the spectrum of the lysosomal storage, neurological spectrum of lysosomal storage disease, and the whole idea of pathophysiology and how it might lead to clinical signs and symptoms, we might focus a little bit on therapy. I will not focus on the workup that is required for lysosomal storage disease. Most of the time, if a storage disorder is suspected, it is fairly easy these days to get an enzyme estimation for any of the disorders, as well as genetic testing. There is panel testings available where a single gene need not be tested at a time, and therefore suspicion of a storage disease is the key. because if it is suspected, then diagnostics are much easier in the past, say 15 to 20 years than they were before. Again, an infantile form of a storage disease is really not difficult to pick up. Uh, in that case, the urgency often is for disorders that have therapy. The likelihood of a therapy working is much higher if the disease is picked up as early as possible in life. And for example, in Pompe disease, the diagnostic delay of 2 months can mean a difference of survival or being on a ventilator or having severe comorbidity. So in infantile forms of storage disease, the urge is to make early diagnosis, but it is very difficult to miss those. The late onset forms of lysosomal storage disorders, on the other hand, are very uh, divergent in presentation, and each of them may overlap with some other more common neurological acquired disorder or a uh, either it's an inflammatory disorder or demyelinating disorder, whatever the case might be. In that case, the likelihood of misdiagnosis is very high. Delay in diagnosis for storage disorders that are late in onset is sometimes to the extent of a decade or so. Therefore, suspicion of a storage disorder is the most important uh, key in making the appropriate diagnosis at the appropriate time. Very often, it is useful to just list out or enumerate each of the suborgans of the brain that are involved. And if more than three brain systems seem to be involved at the same time, say basal ganglia with cerebellum or peripheral neuropathy or eye with cortex, and there is a history of slow progression or neurodegeneration, then a storage disorder should be suspected. Um, Being autosomal recessive, family history really is not relevant most of the times. A sibling might be affected, but not necessarily. And therefore, we don't rely so much on the family history for autosomal recessive disorders to make the suspicion stronger. Uh, the But there is a role for genetic counseling, especially of the siblings, and for family planning, where if an autosomal recessive disorder is diagnosed, and therefore early diagnosis and intervention uh, is still relevant and key for late onset forms of lysosomal storage disorders. Now, as we were saying, therapy for neurological forms of lysosomal storage disorders is more difficult than the other disorders where systemic involvement is predominant and neurological involvement may not be there. And mostly it is because of the blood-brain barrier issue. So on the right, if you see the picture, normal blood vessels, the lining of the blood vessel is usually porous, meaning that the two cells are really not in contact with each other, and that leaves a lot room for passage of molecules or medications from the blood vessel out into the tissue, and therefore for systemic treatment that usually is not a problem. But when you come to the endothelium or the lining of the blood vessels in the brain, these are really characterized by tight junctions, and therefore there is no room for molecules to pass from inside the blood vessel into the tissue. These tight junctions are in addition supported by the glial cells that kind of form a second layer around it, and therefore brain is essentially protected from any macromolecule entering the brain by this kind of a design. So the skull and the meninges have a physical protection around the brain, and the blood-brain barrier has a structural or a physiologic protection for the brain for the brain to not get affected by a number of toxins or other chemicals. Only small molecules can pass, fat soluble molecules can pass, but we are stuck with this kind of a system for any other therapy that we might want to introduce in the brain. Now, in cases such as meningitis, when there is inflammation, there is breakdown of this blood-brain barrier, and that works to our advantage because in that case, antibiotics can pass through, and we can treat illnesses like meningitis by antibiotics because of the breakdown of blood-brain barrier. However, in chronic disorders like lysosomal storage disorders, there is no reason, there's hardly any inflammation and no reason for a breakdown of the blood-brain barrier. So all the current therapies, the enzyme replacement therapies, are not effective for the neurological forms of the disease. So for Gaucher disease, for example, type 1 will easily be treated by enzyme replacement therapy. However, type 2 and type 3, there will be a systemic response. The liver and the spleen size will decrease, However, the neurological manifestations will not change. The neurological prognosis will not change with enzyme replacement therapy. So there are newer strategies that we can apply to circumvent this blood-brain barrier issue. Now, one thing that can be done is that the drug can directly be introduced into the CSF and thereby bypassing the blood-brain barrier. And this can be done either intrathecally by doing, say, a spinal tap and introducing the drug into the lumbar space, or directly placing electrodes into the brain and introducing CSF, introducing the drug into the CSF by that method. Now, just from, as you can see, that it is not the easiest thing to do. uh, Repeated lumbar punctures will usually cause chemical arachnoiditis, and we are already seeing some of the long-term effects of these repeated intrathecal injections in disorders where, like SMA, where there have been therapies designed in that manner. Now, placing an electrode in the brain, of course, being a very serious condition that is always entertained. There are a number of therapies now that are trying to introduce the enzyme replacement therapy by direct placement of catheters in the brain. So that's one possibility. Second possibility is either decrease the peripheral degradation of lysosomal enzyme replacement therapy that is being given. This is done by either inactivating the terminal uh, sugar chain so that the mannose 6 phosphate receptor is not utilized for degradation, and then allowing higher levels of enzyme in the periphery. And so, by sheer concentration gradient, some of the drug can enter the brain. So, that's one other possible mechanism. And we see some places where this is being utilized. Third possibility is using fusion proteins. So, because there can be a receptor mediated uptake in the brain through the endothelial cells, we provide uh, a side chain, or we provide an additional polypeptide which can be picked up by the receptor that is fused with the enzyme replacement therapy. And so essentially, because of this polypeptide side chain, the entire molecule will be picked up, and we'll see that this is being applied in some newer enzyme replacement therapies to allow for ERT to enter the brain. And a similar concept of nanoparticles, where the nanoparticle is conjugated with the enzyme, similar uptake through the endothelium because of the recognition of nanoparticles. So these are some of the modalities of therapies for lysosomal storage disorders involving CNS, and we will go through some of them. Mostly, we are relying either on gene therapy or cell therapy, and then let's see what small molecules can do in this space. So we start with the approved therapy, which is enzyme replacement therapy for neuronal ceroid lipofuscinosis. As we said, this involves direct catheter placement into the brain and an enzyme infused every 2 weeks. The enzyme was approved for late infantile neuronal ceroid lipofuscinosis type 2, caused by tripeptidase peptidase 1 deficiency in patients who are 3 years of age or older. Now, this slowed loss of ambulation in symptomatic subjects. Not much information is available on language or seizure control, which are the two other major manifestations of NCL. The procedure-related complications still are major adverse event. Placement of the catheter may cause CNS infection. And again, the device needs to be replaced every 4 months. So it's a very complicated process. And we are following the evolution of this therapy over time. And let's see how it works out. This allogenic hematopoietic stem cell transplantation was one of the first therapies that was devised for neuronopathic lysosomal storage disorders. It did not pan out for several disorders, but for MPS 1, it is still the treatment of choice. And it's essentially bone marrow replacement. And the idea is that once we replace the bone marrow, the stem cells eventually migrate to the brain and get settled there as microglia, and they secrete the enzyme that is deficient, allowing for a receptor mediated uptake of the enzyme secreted by these microglial cells. And in this situation, then the donor of the hemopoietic stem cell has to be a non-carrier. Uh, for MPS1, this therapy has really panned out to be an excellent therapy, especially if diagnosed early and treated early, the outcomes are fairly good. For other LSDs, this has not really worked very well. So the other possibility, if we don't want to have a bone marrow donor, stem cells are isolated from the patient themselves. Then a gene therapy is introduced into these isolated stem cells, such that now the uh, additional gene expresses the deficient enzyme. Those cells are replaced back into the cell, so there is not much replaced back into the patient. So there's not much chance of rejection of the bone marrow, because it is essentially the patient's own stem cells, and therefore immunological reaction is less likely. And the stem cells that have now been engineered to secrete this enzyme will provide the enzyme in an overexpressed manner. Again, the same idea. These cells will become resident microglial cells in the brain and express the enzyme, the required enzyme. There are some combination therapies like intrathecal with allogenic bone marrow transplantation that is being tried for, say, MPS1. There is also a chemically modified variant of sulfamidase being tried for MPS3 that allows entry of this modified variant into the brain, and therefore expected to have impact for patients with MPS3. All of these modalities are in development, not yet approved by the FDA, undergoing clinical trial. As we said before, we will try ERT with fusion protein, and one of the ones that is being used currently, especially for MPS, is human insulin receptor. And so a human insulin receptor antibody is tagged along with the enzyme replacement therapy. The human insulin receptor will recognize the antibody, allow for endocytosis of the antibody with the enzyme tagged to it. And so these additional proteins or the additional peptides attached to the enzyme replacement therapy really behave as Trojan horses, allowing for the entry of the enzyme to bypass the blood-brain barrier. Some other molecules that are being tried, or some other peptides that are being tried for a similar kind of approach, is apolipoprotein, transferrin, or insulin-like growth factor 2. And then that brings us to gene therapy. Again, we spoke about ex vivo gene therapy, where we isolate the bone marrow cells, introduce a gene therapy in them, and reintroduce the same bone marrow cells into the patient. And that is autologous bone marrow transplantation with engineered cells, and then hoping for the overexpression of the enzyme, and as we said, replacement of the microglia in the brain with these new modified stem cells, and replacement of replacement of the deficient enzyme. In vivo gene therapy is directly introducing a viral vector that has been modified and expresses the deficient enzyme. It is introduced either peripherally via IV, but again, the question of whether it is neurotropic and whether it will reach the brain always remains. So some of the gene therapies will directly introduce this viral vector into the brain parenchyma. This is a one-time therapy, hoping that this viral vector will then continue to secrete the enzyme that is deficient and provide the enzyme replacement that is much needed. Now that brings us to therapies that are under investigation for their ease of administration, which are the small molecules. These can be given orally. They may not have as many adverse events as, say, gene therapy or autologous bone marrow transplantation. And but they do have their own limitations in terms of whether they will work on all forms of the disease and whether they'll be as effective as, say, enzyme, either ERT or gene therapy. So a pharmacological chaperone. This is a very opportunistic kind of an idea, which has really worked for some of the lysosomal storage disorders. As we said, that when there is a missense mutation that does not lead to a premature termination of the protein chain or degradation of the protein chain, there may be a misfolded mutant enzyme that is actually produced by the endoplasmic reticulum. Now, that is actually produced in the ribosome. However, because the cell has a mechanism to recognize a misfolded mutant enzyme and send it for endoplasmic reticulum related degradation of this misfolded enzyme, the residual enzyme activity may actually be very, very low. So there are some endogenous chaperones that we have, such as heat shock proteins, but in this situation, we are giving an exogenous chaperone that will stabilize that misfolded enzyme and allow that enzyme to reach the lysosome and execute whatever residual enzyme activity it is able to do. Um, in this, because even a slight increase in the residual enzyme activity can really mean a big change in the phenotype. These being small molecules are not expected to have very big side effects, and therefore when they work, this might be a very effective mode of treatment for the disorders caused by missense mutations or more milder mutations. Now the table lists a number of enzymes and their specific chaperones. So as expected, for each enzyme there'll be a specific chaperone molecule. um, so far, the one that is approved is for alpha group galactosidase, and the molecule is migalastat. Uh, Whether this will have impact on the neurological manifestations of Fabry remains a question, because Fabry is very specific. The neurological manifestations are not necessarily related to the primary involvement of the brain, but because of the blood vessel involvement and stroke-like syndrome related to uh, the blood vessel involvement. Ambroxol is used in in Gaucher disease, even in neuronopathic Gaucher disease. There have been trials of pyrimethamine and Hexa. However, tolerance of pyrimethamine on a chronic or a long-term basis is not really the best. So more work needs to be done in that regard. Now, similar small molecules that are used as chaperones may actually work as inhibitors of the enzyme when they're given in very high uh, or a slightly higher doses or slightly higher concentration, because they do bind to the enzyme. And so if the concentration is high enough, they may actually be inhibitors of the enzyme. And this is the idea behind substrate reduction therapy. Small sugars that can attach to enzymes and really behave as enzyme inhibitors. And therefore, for Gaucher disease, there are two substrate reduction therapies approved, miglustat and eliglustat. Uh, and they are ceramide synthase inhibitors, which lessen the formation of glucosylceramide, the molecule that is accumulating in Gaucher disease. So if we cannot take care of the accumulated molecule, the idea here is to not let the accumulated form be produced in such a high quantity so that we maintain the balance of non-accumulation. A couple of other cyclodextrin was tried for NPC1, intrathecal adrenal intravenous, and then genisterin for MPS. So these are some of these substrate reduction therapies either approved or being worked on. Now, for diseases, say for Duchenne muscular dystrophy, there has been a approved therapy for read-through of read-through of the DNA, that is a piece of the DNA that is causing pathology. So in this case, for example, in the lysosomal storage disorder situation, if we can read through the premature stop codon and continue the protein chain to be formed, it may actually again have a residual enzyme activity that may be relatively good depending on where that premature stop codon occurred. And this is being tried as a methodology of therapy for lysosomal storage disorders, where we allow for read through or read through the stop codon. This is already known for drugs such as aminoglycosides like gentamicin. However, the drug itself, gentamicin, is quite toxic and has side effects of kidney damage and hearing loss, and therefore cannot be used on a long-term basis. So similar drugs are being tried to see if we can bypass the toxicity of aminoglycoside and use it for therapy for MPS. As you can see, this designer aminoglycoside. And ataluren, which was originally tried for Duchenne, is maybe tried for Krabbe disease, but we are yet to see any action in that regard. And then protein homeostasis is affected in lysosomal storage disorders because of the accumulation of the substrate and the downstream effects from there. and therefore use of proteostasis inhibitors as treatment for, or as a treatment modality, I would say, for NPC has been tried both with vorinostat and bortezomib. Again, we'll see if it eventually becomes an approved therapy and what is the degree of improvement that occurs in symptoms or presentation related to these drugs. And some new modalities of therapy are coming for symptomatic treatment of vertigo and ataxia therapy in Tay-Sachs and NPC. Now, these are all curative therapies, as we saw, where we are trying to either increase the enzyme replacement enzyme activity or trying to replace the deficient enzyme. However, it is very important to also focus on symptomatic treatment of neurological symptoms in lysosomal storage disorders. Most importantly, seizure control, which can be very, very difficult in a number of gangliosidosis and even other lysosomal storage disorders. Um, Simple therapies for management of, say, drooling, or management of spasticity, management of extrapyramidal symptoms such as dystonia or Parkinsonism. Whatever therapy could be offered for symptomatic benefit is always balancing it with the side effects of the drug, but always makes the management of the patient easier, as well as improves the quality of life for the patient themselves. And so there is no reason to underestimate the use of symptomatic therapy for each of the neurological symptoms in lysosomal storage disorders. Uh, Additional therapies such as physical therapy or use of devices, say, for prosthesis for spasticity, or even Botox-like injections for relieving of spasticity. All of those could be tried for each of the individual symptoms, neurological symptoms in lysosomal storage disorder. This particular presentation does not focus on the symptomatic therapies, but again, it's very important to identify and treat, or identify and try to ease the discomfort related to these symptoms of lysosomal storage disorders. Uh, Hopefully, some of the upcoming therapies provides a breakthrough for availability of the enzyme or the pathology modification in any of these lysosomal storage disorders, and that is what really the field is waiting for a breakthrough uh, to allow the neurodegenerative diseases to be ameliorated, and not just in lysosomal storage disorders. This is a need or a requirement across the board for neurological or neurodegenerative disorders, and we'll see how the field does over the next 10 years or so. Hopefully, this presentation was helpful and provided an overview of the neurological involvement in LSDs. And now I think it's time for any questions.
I would like to thank Dr. Sathe for this very detailed and almost enlightening presentation. I'm particularly thankful to her because she also covered the therapeutic options, which we did not so far touch base. Before I open the Q&A session, I would like to invite the attendees to do the brief survey, and also I would like to thank all our sponsors that helped us to actually put these CME sessions in reality. So I will read the questions. Please, the ones that have a question, submit through the Q&A that I will present those questions to Dr. Sathe. And also, please fill out the survey that will help us to improve the CME on lysosomal diseases. While waiting for the question, I'm just gonna ask actually probably a hypothetical question. So we are now this is the era of gene therapy, I think. Is that right? We're moving from the 2010s the small molecules, substrate inhibition, the chaperones to gene therapy. So obviously, we're having the first in human trials for the primarily neurological disorders such as GD2. So, what do you think we can achieve by gene therapy? Meaning, are we gonna be able to successfully treat, I'm not saying cure, the disease, or we are going to see a modified phenotype that is going to be emerging after gene therapy. This is especially true that we were discussing this about 20 years ago or 15 years ago for Pompe disease, infantile Pompe disease. It evolves to something else with the success of systemic ERT.
So I think, Ozlem, you're right. The best that we can expect at the time is that we have a modified phenotype. It will also very highly depend on at what time the therapy was initiated. So earlier the treatment, then the possibility of a better outcome is much higher, and that's true for any neurological disease. And this, the permanent question of diagnosing a disease before its onset, and then the possibility of treating it before the onset of symptoms, but then how do you monitor, given the variability in the presentation, whether the timing was right? So that will be a question for a long time, I think, a while.
Yeah, I think it's, I mean, I just want to make this as a little chat for the listeners or the audience. The reason is, I mean, this brings us to the question whether some of the presentations such as GD2, is it already too late to treat these patients? Because, I mean, we have some evidence that actually some phenotypes such as the ichthyotic or the colloidal baby phenotype for GD2, we know that it's already, there is in utero effect. The patients are affected. Similarly, the ones that present with hydrops, there is indication there is in utero involvement. So how we would, obviously with the newborn screening, we will be screening for the genotypes and the enzymatic activity. And the figure you showed, actually the one for the type 3 Gaucher disease, so it all involved 4 patients with GD3, and they all had almost close to 0 enzymatic activity. And so basically some of them went to college, some of them died. Actually, the baby died of really with myoclonic epilepsy years later, and the middle patient actually that was transplanted years ago and they died of complications. So I mean, genotype is helpful obviously to predict, but is not 100% clear too whether some patients will go to GD2 versus GD3. I mean, obviously there is a neuronopathic involvement. So how would you comment on the genotype, phenotypes, and how would you choose the patients for such a trials?
So, again, doing a trial before in pre-symptomatic cases is a very difficult task, given that unless there is a very, very strong biomarker or there is a very clear-cut estimation of progression and time of onset and such, we barely ever see trials that are initiated prior to onset of symptoms. At least thus far, that would be a very challenging task. And that's the reason for emphasis on the biomarker discovery and so on and so forth. If there's no endpoint, if the patient has no symptoms, then there's no endpoint to demonstrate.
Yeah, exactly. Yeah, is it by luck or is it the success? Is that right? I have 2 questions in the Q&A part. So first question is, can we infer that the neurological symptoms seen in LSDs like optic involvement, demyelination, all have the same etiology or the involvement of astrocytes, glial cells, etc.? That's the first one.
Well, there is always involvement of the astrocytes and glial cells, but for most part, we would believe that it is a reactive involvement because the primary metabolites in lysosomal storage diseases are actually components of the neurons, either of the gray matter or of the white matter myelin. And very often we believe that the primary dysfunction is either of the myelin itself or the neuronal cell body itself, and the astrocyte involvement is reactive. I mean, there are leukodystrophies which are primarily glial in onset, such as Alexander disease, but those we consider to be rarer, that the glial involvement is primary. But with any degenerative disease, we always expect some reactive involvement of the supporting cell.
Well, the second question is there any open trial for late onset disorders? I mean, there are trials for late onset disorders.
Yeah, I know that there's one at least for late onset Tay-Sachs.
Yeah, and you're asking for Gaucher. I mean, usually there is late onset for Gaucher, what we mean by either GD1. Usually the trials start with the adult patients anyway, so they involve the late onset patients. Yeah, can you comment on the particular late onset Tay-Sachs? Or
I think it's a chaperone therapy for late onset Tay-Sachs. That's an ongoing therapy. Again, I'm not very sure of what the endpoints are, but given the very heterogeneous presentation, that will again be very challenging.
Yeah, if we are talking about the attenuated forms, actually, there are gene therapy trials that are currently available for the attenuated forms of MPS too. So they're starting with the non-neuronopathic MPS, just systemic involvement as a proof of concept. So in general, it's as a proof of concept, we start with the adult presentations in the adult patients. Usually, as a rule, these patients have the later onset or the attenuated forms.
Yeah, but I would also like to say that usually what happens with diseases like SMA or lysosomal storage disorders is that the trial is usually initiated in the severe most forms, if they're infantile or late infantile. The assumption being that if it worked there, then the demonstration of efficacy in a later onset form will be easier. And sometimes the FDA is considerate and may give approval as such for all forms if there was a demonstration of benefit in the most severe form. So sometimes that's a consideration as well.
Yeah. All right, I guess these are the questions, and we thanked all the audience, and stay tuned. This actually concludes our first year of the CME, so stay tuned for the season 2. Thank you.